Thank you very much. So our surgery is ready. Now Dmitry will tell us the case history of the patient. The topic is going to be discussed tomorrow in the tomorrow lectures. This is deep diagnostics between primary sclerotic cholangitis and cholangiocarcinoma, which is quite a complicated problem for a separate lecture, but today at least we shall have an opportunity to observe our specialist working in real time. So you are welcome. The next presentation will be very interesting to all the specialists because we are talking about the patient of 40 with a long follow-up by GI specialists starting from 2008 with ulcerative colitis. 2012, they reconsidered the diagnosis and there was a diagnosis of Crohn's disease because there was also certain lesions detected in the iliac bowel, and then there was the jaundice developed with cholestasis, and the virus hepatitis and antigens were negative. Starting from January 2014, the patient was observed in our clinic, and in January there was an examination done. Consecutively, we performed MRI, which detected bile duct, common bile duct stone with the concrements, cholestasis signs, hepatomegaly with lymphadenopathy in the hilus of the liver. And we sent the patient to EUS because dilatation of the liver ducts was not detected. So we used the EUS method, which detected strictures in the cholangiocarcinoma due to the significant thickening of the wall, the abdominal lymphadenopathy. What is also very interesting that in the utmost right image we detected a malformation in the cholangiocarcinoma, which had certain relation to the wall, very narrow pre-wall, and it made us perform ERCP, which was performed twice consecutively. We wanted to look through the biliary tract, and we detected certain lesions which showed primary cholangitis. You can see enlarged and distended gallbladder, and the pre-wall malformation in cholangiocarcinoma was not very well detected here, but under the X-ray control, the biopsy aspiration was performed from the same side, and you can see the histology results here that show tubular papillary intraepithelial neoplasia on the background of chronic erosive and ulcerative inflammation, and the signs of neoplastic lesions in the materials were not detected. Histology was performed, the second histology was performed on the in 2 months, and you can see further on that the patient was on dynamic follow-up. In October this year, we had another set of tests and examinations. In the lab tests, you do not see certain changes in the blood, but cholestasis still persisted. In the biochemical test showed it. In terms of the biomarkers, the CA19-9 was elevated, which made us think about one of the complications. sclerosing cholangitis and developing into cholangiocarcinoma. And our today's dynamic control is a secondary cholangiopancreography in order to clarify the changes and the lesions in the cholangiocytes if compared to the previous period. And our surgeons will be doing cholangioscopy via dissected papilla and for the secondary morphological examination. So.
Геннадьевич, мы вас видим и слышим.
Thanks a lot. We can see you and we can hear you. We haven't said anything yet. Thanks a lot, esteemed colleagues. We made this presentation more detailed because it's a very interesting case. Tomorrow we'll have the same case or similar case. So our plan is to do RCP and to do with possible targeted biopsies, and we'll switch to AUs. We'll try to aspirate the lymph nodes. So, Alex, are you in duodenum? Yes. Do you see endoscopy or X-rays? We saw you. Now we see endoscopy, and we hope to see. I'll try to have all three pictures on screen. Now we are in the duodenum, and I'm giving floor to Alex.
Of this patient, we discussed about her situation. What do you do now?
So, as you can see, we already cannulated the papilla. There had been a sphincterotomy done before, not as large as in the patient before, but this is not necessary as well. So we prepared this, and now the first thing we want to do is to inject contrast into the common bile duct and the peripheral ducts to see the biliary tree and to get an idea about the status of the biliary tree.
И, Виктор Анатольевич, мы сейчас, если вы не видите...
And if you can't see the X-rays, better to switch to X-rays.
So you see that most of the contrast is flowing out directly into the large gallbladder. So we need a wire to cannulate the intrahepatic ducts, because otherwise we won't get very far here. Yeah, and the way the wire is taking is showing us that something's wrong with the bile ducts. Okay, but now we are inside the right hepatic duct, or the right lobar duct.
Yeah.
Okay, inject please.
Yes, please.
Okay. And what you can see is that the bile ducts here are irregular. You see that there's an irregular surface of the bile ducts. This is not the typical cholangiogram you get, but this is not the worst one I've seen. But there's not much contrast going inside of the liver. Now, why don't we try to cannulate the left side, please? Yeah, yeah.
Okay.
Yeah, thanks. I try to follow you.
It's push me.
Yeah, no, I'm pushing you out. So try to pull me. Try to pull me in, please. No, pull.
Wait a minute.
Okay. Yeah. Try to pull.
Okay.
There
Yes.
we are.
Okay.
So
Contrast.
we've been working together for many years, as you see.
Yeah, it's true.
Good. Inject, please.
Yes, please.
Okay. And I've got rather large difficulties advancing the catheter here. And what we see is that there is a lot of peripheral ducts there. Sorry, there, but the left hepatic duct seems to be somewhat narrowed, which is a sign of inflammation in itself. Okay, so why don't we leave the wire here and
I just
yeah?
push it. Okay.
Okay, yeah. Maybe yeah, push it until it bends.
Be careful.
No, I've just lost my position at the papilla. Try to recover that. Sorry about that.
К сожалению, очень неустойчивая позиция.
Regretfully, it is a very unstable position in duodenum. Since pressure with catheter and guide-wise rather strong, we lost cannulation. We jump back to the stomach, Alex will come back to the papilla and we will proceed. We'll repeat the procedure. Мы опять.
Cannulate. There you go.
Uh-huh.
Try to find a secure position. X-ray. Advance the wire, please.
I try to do
If
it.
possible.
Wait a minute.
Yeah.
Wherever.
You see the catheter just behind the scope.
Okay.
That is now wire, wire, wire.
Yes.
And you see already how difficult it is to advance
Yes.
the wire through the distal portion of the CBD. Now try to cannulate the left hepatic duct, please. Yeah, there you go, there you go.
Just
Yeah, that's
okay.
good, that's good. So pull, 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 pull me. Just a bit.
Тут нужно сказать, что вот сейчас
I should say here is a special catheter of Olympus, which makes possible to it's manageable governing catheter.
Change, please push
Okay.
the wire while I pull the scope.
yeah.
The catheter, sorry.
Okay. Wait.
Sorry, I'm too fast. I'm sorry.
I'm too slow.
No, this is my
Yes,
my
okay.
worst problem is my impatience. Sorry.
Okay. Сейчас мы меняем
Now we
instrument. We have special balloon for cholangioscopy. So we use guide wire right now and move out the catheter and then stop.
No, the wire.
Wait a moment. Видите, есть небольшие сложности.
you see there are some technical difficulties since the duct wall is very dense. We cannot move the guide wire rather far away, but we're lucky that we actually can get into the into the ducts.
What do you think about if we will use right lobe? for this?
No problem. Just
Because it's more longer and
Yeah, no
it's more it could be more stable position.
just to get the yeah, that's okay. That's fine. Good. Now, exchange.
Okay. Ай-яй-яй. Таким образом, сейчас мы меняем
So thus we change the tool. We'll take a special balloon. We'll move it to the right lobe duct. We're in the right lobe duct. We will inflate this balloon, and then we will use it as a guide wire to move the ultra-thin endoscope into the bile ducts to see the zones of interest, and we'll do then the target biopsy. So you will see how we're going to do that. At the moment, we change the tools.
this type of cholangioscopy, this equipment and this instrument. I know that you used it in German too.
Yeah. So what? Wait. Oh, this is very much.
Opa.
Yeah.
No, it's
still
okay.
So what we are trying to do now is direct per-oral cholangioscopies, meaning that we don't push the scope through the working channel of the duodenoscope, which is possible as well with another type of equipment, but we try to exchange the large scope against the smaller scope, which we put directly into the bile ducts, which has some advantages over the mother-baby scoping, because we can get larger instruments in with larger working channels, which makes it easier to do therapeutic interventions, to take biopsies, whatever. The only thing which is a little bit cumbersome is that we have to bring in the other scope. And we cannot do this very well just in pushing in the scope and entering the bile ducts, but we need some help, some accessories. And some of that you will see just now. I'm advancing a very tiny balloon into the intrahepatic bile ducts now. And we need the wire as guidance here because the balloon is so small.
somewhere in the near the elevator.
Yeah. Not yet, not yet.
Not yet, but I have some. I don't know.
No.
Something wrong with guide wire.
Yeah.
Есть у нас небольшие тут сложности.
We have some technical problems with bringing in the guide wire. It's quite hard, for some reason it's quite hard to move it in.
A technique here, advancing the small balloon over the wire. Pull a bit, pull a bit, pull a bit.
No, Alex, I think we have trouble.
Okay, good. So
It's broke.
yeah, no problem. We exchanged the instruments.
Yes, we have
So
to exchange the
can you
instruments. Okay, put
Take
it
out
out.
everything.
Yeah, I think so.
Yeah. Okay. Good. So no problem. We
Мы
start
сейчас,
again.
да,
Start
сейчас
fresh.
мы поменяем инструменты.
We'll change the tool. The catheter with 25 guide wire.
Equipment to use, and it's necessary to have a well-prepared patient here, and it's necessary to have well-prepared equipment. We are just exchanging now. The interesting question here is, how does the inner wall of the biliary tract look like? Because now we've got the presumed diagnosis of primary sclerosing cholangitis, meaning this is a inflammatory disease of the biliary tract. And the problem, as you will know, of course, is the high risk of malignancy in those patients. And I've personally, and I know that other doctors have the same problems, find it very hard to identify patients with primary sclerosing cholangitis and cancer, early cancer or dysplasia early on. Most of the patients we see with a cancer, they just present in a stage where we cannot cure them anymore. And in an ideal world, we would find early that there is cancer in those patients when there's still a chance of curative resection.
Okay, Alexander, what do you think about oncomarkers in this case? Because the level of CA99 in this patient is very high.
It is troublesome, the level of CA99, but again, there is no clear cutoff. There have been studies on what's the cutoff of CA99, but whatever cutoff you take, you will never reach a specificity of 100%, because when there's cholestasis, mechanical cholestasis, there will in many cases be elevated CA99 levels, and we've seen that in a number of patients, and I've seen 5-digit numbers of CA99 where we were pretty sure that there's malignancy there, but when cholestasis resolved after treatment, the level dropped down and we never found malignant tumor here. Okay, so the wire is already in.
Yeah.
So is the catheter. Try to advance the wire, please.
I tried to do it, but it's okay.
There we are. It will be tough to advance the scope later on because we've got a distal stricture here. So pull, pull, pull.
Pull, 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 pull. Okay.
Okay, now advance the wire. Good. Pull, pull, pull. Withdraw. Okay.
Okay.
Yeah. Maybe you should pull a bit.
Pull.
Pull,
Okay.
pull a bit. Pull a bit. Pull a bit.
Okay.
Because we're not yet
Yes.
in the right position. Pull. Okay. Try to advance the wire. Some more. Some more. Some more. Maybe we're in the cystic duct. That's possible.
Maybe, yeah.
Yeah. So I go down a bit. Maybe you try like this. This looks better, but only for a second.
What do you think about contrast?
Yeah. Maybe we should.
Sometimes
go to
we
extremes and inject some
sometimes we
contrast.
have to see what we do.
Yeah.
Contrast. Yeah.
Good.
Okay.
So let's see. Yeah, look. We're in the cystic duct. That's the problem. Good. So withdraw, please. Pull, pull, pull. Yeah. And now, pull, pull, pull.
Just a moment.
Again. I think you have to come down all the way, right? And now try to advance Yeah, that's better, that's much better. Yeah,
Yeah.
There we are.
So,
Good.
welcome back.
Welcome back, right. So, put it, yeah. Now, why not exchange, okay?
Okay.
Let's try
Just
it.
a moment. So it's
So, in PSC patients, it's very tough. There's not one single method of doing proper early diagnosis of cholangiocarcinoma, and you always have to combine your modalities: CA19-9, transcutaneous ultrasound, ESCP, and even cholangioscopy. And I hope we are going to get some nice pictures from inside the bile duct, and you will see how much changes have been to the bile duct wall. So now we've got a different wire in place, which is a little bit smaller in diameter. And again, we try to advance this tiny balloon, which is a very delicate accessory, but very helpful in these cases.
Is the mother baby stroke?
No,
No.
It's a direct per-oral cholangoscopy, meaning that we exchange. Yeah, we try to exchange.
Okay.
Yeah.
So you try to go inside with the scope.
Yeah, this
Right,
is special balloon when we
So I
put inside the.
describe this technique first. With Waxman.
Yeah. So please tell us what to do.
Use to place the transnasal scope.
Yes, the same. Here it is.
So here's the tiny balloon. You can see two radiopaque markers here, or just one. Okay, and I'll try to advance it as far up as possible, so I intubate a smaller intrahepatic duct, so the balloon will keep me fixed firmly when later on I try to advance the smaller scope via the balloon.
Okay, I think we're inside.
So that's good. Okay.
Воздух.
So what we do now, this balloon is not intended for therapeutic purpose, but just to work as an anchor. So we have a straight line from the mouth to this biliary tract where we can advance the smaller scope. Okay, so now the balloon is being inflated. Because it's so tiny, this takes some time.
Yes.
Yeah?
Okay.
Good. So what we do now is that we leave this balloon in place and remove the whole scope, the larger scope here. And hopefully we be able to advance then the smaller scope via this balloon which still is in place.
And what do you think to use a contrast right now just to see what's happening with balloon?
You want to put I mean, when you got a good feeling about the balloon there, I can try if it's still. No, it's still moving. So let's see. No, this is not. It's not inflated yet.
I'll try one more time
So,
because I just feel very bad resistance here.
Okay.
And we use a gas, so it's not a liquid, but it's
Okay. Close it.
okay.
Okay. So. No, I'm afraid this balloon is not anchoring the way we like. No. I can still move it quite freely, so this will mean that the balloon is not inflated.
And what is right now?
Let's see. Still moving.
Strange.
Yeah.
Okay, could we remove it and try to inflate outside?
Sure.
Just to see.
But please push the
Yes,
balloon.
of course.
Push the wire, I mean.
I understand you.
Евгений Геннадьевич,
Да.
мы все
Eugene, we do understand those, we do see those technical problems, but if you feel that you need more time to assess the technical devices, we have a lecture as a backup, so we can make a break so you will feel more comfortable. Yes, yes. Okay, we'll try to inflate the balloon outside, but for some reason we can't inflate it. Some problem with that. It's attempting to get inflated. Now, if within 2-3 minutes, if we didn't do that, now it's working.
You won't get the air out.
How to deflate it?
That's the problem. Yeah, because there's this valve inside.
Yeah.
You won't be.
Там есть иголка, по-моему.
Yeah.
There's a needle somewhere. Let's cut it.
Inflate this, but not deflate this.
Yes, but we try to maybe cut it, and we have special needle
Okay.
to inflate it again.
You can easily see how complex and delicate the procedure this is, and this is the reason why it's done in selected patients and in very proficient centers, as this is one. And we've done this procedure quite a number of times here, but it's sometimes a little bit cumbersome to work with this tiny equipment.
I think, Виктор Анатольевич, если вы нам дадите...
Victor, if you give us 5-10 minutes, I think we will resolve this problem, and we will then contact you once again.
To cut the guide wire.
Евгений Геннадьевич,
Да.
ну тогда мы...
Well, then we'll ask Sergey to cut the lecture on several sections, and we'll stay in contact. When you are ready, please signal us, and then we will connect.
Now we're going to make a small pause and come back to the operating room.
Проблема по поводу холланд...
Regretfully, we have some technical issue with cholangoscopy. Like in phrase, like in quotation, that tools cannot work while people still can work.
3
Okay.
perform RCP
and we saw the intrahepatic ducts already. Now in the time we were away, we've rotated the X-ray machine a bit, so now we can see the common bile duct properly. And when we inject here, you see that in the upper part above the scope there's a fairly smooth wall, and down here in the intrapancreatic portion you see that there's a narrowing of the duct. This can of course just be the intrapancreatic duct, as we discussed earlier, but in this case I've got difficulties even bringing the catheter up. So this is the portion of the bile ducts which is giving me most trouble right now, and what I'd like to do is to take samples from here. Because even when we had a very nice cholangoscopic picture, we still need tissue to send to the pathologist to get an idea, is this just inflammation or may there be something else growing inside it. So what we do now is we've seen where the problem might be, and now I'll try to take some biopsies. The patient already received brush cytology some time ago, which was so-and-so, not really without problems. And now what we try now is to go for larger biopsies, to take a larger biopsy forceps, enter the bile duct and try to take out proper chunks of the wall. Okay, so now we exchange, or I take out the catheter, I leave the wire in place because it gives me a good idea of where I have to aim the forceps, because advancing a standard forceps into the bile duct can be a little bit difficult because it's because it's very stiff. We try anyway. So leave the wire in place. We do a quick exchange here. So good. You can withdraw the catheter without putting too much stress. Right. So with the wire in place, I can now advance the forceps.
Щипцы.
The wire, of course, has not any function as a Seldinger wire now because the forceps is not an over-the-wire thing, but it's good to see where we're going. And I'll always get a good impression whether I'm in the common bile duct or in the pancreatic duct, which might happen as well. And taking biopsies from the pancreatic duct will result in massive bleeding. Massive bleeding and, of course, pancreatitis afterwards. So I try to direct the forceps in here. So now it's somewhere inside. This is the correct duct. This is why I leave the wire in, because now I'm pretty sure that I'm in the common bile duct. Please open the forceps. Open, open, open.
It's open.
It's open, good. So I try to put it into the wall. Now close. And take out. Let's see. I didn't have too much of a feeling of pressure on it, so I'm not very sure about the biopsy, but we'll see.
Yes, Alex, but one question. Why do you perform biopsy from this part of CBD?
Yeah.
Why don't you perform biopsy from the hilum
This
in
is
this
what
case?
we are doing this one after the other. So we need a number of different pathology pots, small pots. This is distal third of the CBD. And I'll try to take at least 3 biopsies here, and then we'll advance slowly into the proximal portion.
And a couple words about X-ray picture. What do you think about this X-ray picture, about this situation with so thin?
Open the forceps, please. Open.
With so thin, it's open.
Is it open? Okay. It's moving very easily. So I try to press. Yeah, now it's open. Good. Close. Yes. This is good. That's a good one. Hope I don't catch the wire. Good. Okay.
So a couple words about X-ray picture, about these intrahepatic ducts.
Right.
What can you say?
What we've seen is that the intrahepatic ducts are not very long, meaning the expansion of both lobes is not too much, which could be a sign of peripheral atrophy. And then we've seen that the ducts have mild irregularities in the wall, which again points to inflammatory disease of the biliary tract. So a little bit of blood is coming out, showing us that we at least got a little bit of the wall.
With the Salvizio?
No. I always get dizzy by looking at the pictures. So open, please.
It's open.
Okay.
Здесь сейчас была речь о такой.
Now we talked about such system like CO cell easy. That's a system which makes possible to do microscopy in vitro. Special tools that get into the ducts and make possible to see the mucosa of the ducts with a resolution of about was rather good resolution, was a good up to 1,000 times. It could be magnification.
Not very large, but we have some real histology samples from the distal CBD. Now I try to advance a little bit further up.
Виктор Анатольевич, скажите, какая картинка сейчас?
Could you tell me, please, what kind of picture you see?
Мы сейчас видим вас, и мы...
Now we can see you and we can see X-rays. We don't see endoscopy, but I think we don't need it. Yes, right. Through papilla, we move instruments. And endoscopy picture was quite nice during the first procedure. Technically, it's all the same. And Sergey has a question and a comment.
Okay, yes.
Okay, да, мы внимательно.
Yes, please, we're listening to you. Could you tell me, please, Evgeny, since you do multifocal biopsy, it is clear that the material you're taking, it should be clearly marked and said in the document. So first 3 biopsies are done from one zone, then you go up to reconstruct the morphology using those because they might be different. The pictures we will have, they will be different. Yes, we do work the same way. The material is placed in different tubes, and it will, of course, all will be marked. And another question. You place the biopsies into the formalin or transportation medium. We use formalin. It's formalin.
About it is that it's a real histological sample. Whenever you use brush cytology, you get single cells, and he can take a look at the nuclei and that stuff, but he cannot tell anything about the architecture of the tissue. And this is different when you get larger chunks with a larger forceps here. So open, please. So this is the runoff of the cystic duct. So I'm taking biopsies of the common bile duct and the cystic duct. Please close, please. That's a nice one as well. Okay, good. So what we do now is some kind of histological mapping of the common bile duct. Of course, you won't get the whole surface, but you will have samples from different levels of the common bile duct. And as long as you label the histology pots correctly, you get an idea of where's more inflammation, maybe where's a dysplasia, and you get an idea of whether you have to do more.
Is it enough for biopsy?
I'd like to go to the hilum. This is the toughest part, going to the hilum, because
it's from the cystic duct.
Might have problems crossing the insertion of the cystic duct, but we'll see. Up to now, it's going well. So that's a nice forceps. Anyway, it's not too stiff, so it can be inserted quite easily.
Yeah, we usually use the same forceps for our procedures.
Good. So now I try to advance across the cystic duct. And this.
But it's look like a stricture. Oh, yes, you jump.
No.
Yes, you cystic duct.
Yeah, that's it. So what helps, what can help there is manipulating the scope a bit. No. Of course, tumors can also arise in the cystic duct, but my idea now was to go to the hilum, which can be difficult.
Yes, but in other case, the next option is we try to perform a FNA of lymph nodes here.
Yeah, that's
now after this procedure.
Anyhow. Yeah, I just try maybe 1 or 2 times more, and if this doesn't work, you can always take a brush cytology out of the hilum, of course, because the brush is wire guided. Different to the forceps here. I just try it for maybe once or twice. And if it doesn't work, we go for FNA of the lymph node. So now we are up. Okay,
yes.
Good. Open, please.
It's open.
Yeah. And close. And, yeah,
excellent.
That's one.
Yes, вы видите, да, как во время.
As you can see on X-rays, the forceps are closed. They pull the tissue. It means that we took a nice piece for biopsy.
What is your next plan?
This is by any standard not a full-blown PSC cholangiogram. We saw some changes, and we saw the MRI before, which gave us a good idea of what to expect. And always when you've seen the MRI, you've got an image in your mind which you compare to when you do the direct cholangiogram. This lady definitely needs follow-up. Meaning, even if we find now in the biopsy, if we find only mild inflammation, this lady needs follow-up, because she will at some point develop more severe strictures. At some point she will develop liver disease, and I think we will have to see her for at least once a year in all her life. Not necessarily for ERCP, but at least for MRI, ultrasound and clinical examinations. Okay. Good.
Okay, now we can change endoscope.
We can. Yeah.
So we have Виктор Анатольевич, мы сейчас.
So now we will change the tool to the ultrasound. So we have 3-5 minutes to ask questions to Alex from the audience. And Michael will correctly translate the questions.
And maybe some questions from audience, okay?
Good.
And Mikhail will translate you. There, I mean, there.
Around,
Yes,
okay.
go around.
Да, ну вот Виктора Алексеевича нет, он вышел из аудитории. Вопросы?
Victor is not here, he's out of the audience at the moment. So if there are any questions while they change the tools, so please ask your questions. Sergey, what do you think about this procedure and the perspective, so to say, of taking that material, not only cytology, but histology as well? Well, with regard to cytology, with brush biopsy, it's quite promising, and it depends on the pathology when you do it. But as I said 10 minutes ago, sensitivity of this method is quite low. That's why of brush biopsy sensitivity is quite low, but biopsy is very good. But the first demonstration when you use bucket to remove the stones, it was much larger. But biopsy forceps, they were very small, so it makes harder for us to diagnose the disease because the biopsy is very small. But these are standard, conventional biopsy forceps. You will get the same size of biopsies when you take biopsies from the stomach. So, in any case, when we talk about the targeted biopsy, taking the material directly from the intraductal neoplasia, it might be sufficient for differential diagnosis. Well, the question which is still unresolved, it is when we see the intraductal neoplasia with the epithelium positioned within the duct, and if we don't see it in case of carcinoma, if it's invasive or non-invasive. This either hard to resolve this task or even it's possible.
How often do you see the same patient, the same situation, and what is your diagnostic tactic in this situation?
Usually, we see patients with a presumptive diagnosis of PSC who are referred from an outside hospital. And then the first thing we do is we do an MRI. Because in many of those patients, you already are able to distinguish the distinctive patterns of PSC in the MRI, and you don't need ESCP for that, for diagnosis. Only in cases where MRI is performed in a good manner, but still the radiologist is not sure. Sometimes we do diagnostic ESCP, which is not a common indication anymore. And then when the diagnosis of PSC is established, I have a long talk to the patients to tell them that this is a lifelong disease, which will maybe ultimately need things like liver transplantation, but in the first place, what is important is to preserve liver function. And as we know, liver function is only preserved when the bile is flowing. We have people come to our place at least once a year for evaluation of their bile ducts. A, to see if there are strictures which have to be treated so bile can flow again, and B, to see if when there are strictures, is there any chance of malignancy? And this is the most difficult part about PSC patients. Seeing them once a year, seeing that there are no new strictures, this is a good thing. We would use MRI for that, one MRI per year. But when there's a new stricture, which has not been there in the examination before, I always try to get people to give consent to an ESCP, because then we can do two things. We can A, take biopsies of these strictures and send them for pathology to see is the newly onset stricture maybe malignant, and B, treat the stricture by balloon dilation. And when I see that the stricture is responding to balloon dilation, I would repeat this twice a year, as long as the stricture is not a problem anymore. And then the patient goes back to MRI diagnostics for the following years, until in MRI there is another stricture, for example, which is suspicious of malignancy. Then the whole thing starts again. I think that in PSC patients it's very important to keep a good relationship and to see the same doctors.
Yes.
Patient and doctor have to have a relationship because they will have to negotiate their way through the years of those patients. And you have to see, is this patient someone who's developing malignancy, or is this patient someone who's developing severe liver disease indicating liver transplantation at some point.
So
This is typical of the thickened wall. It might be. Can be.
Спасибо.
See in autoimmune cholangitis also. When you
Дмитрий Викторович, а можем мы переключиться сейчас на...
Dmitry, can we switch to ultrasound? Мы сейчас начали...
Виктор Анатольевич, с возвращением. Вот сейчас я...
Victor, it's great to see you here. I now would like to give a floor to Alberto.
Say a couple words about the picture that we see.
Yes. So so this is the bile duct, and as you can see, there is air inside. Clearly, you just had an ERCP, but the wall of the bile duct are thickened and irregular. So this condition is usually seen in autoimmune diseases of the bile duct. Like sometimes when you have autoimmune pancreatitis, you also have the duct that looks like this. And in case of autoimmune pancreatitis associated with autoimmune cholangitis, usually that kind of thicken disappears with also with the steroids. So you can see a rounded lymph nodes. For example, at Mayo Clinic, where they do transplant for these patients, also for unresectable hilar cholangiocarcinoma, if they found the lymph nodes, they biopsy all the lymph nodes, because if there are metastases, the patient is not a surgical candidate anymore. But this is a different situation. It's a hilar cholangiocarcinoma for liver transplant.
So this is intra...
Yes, this is the
pancreatic part.
So you can see air. What is this?
Lymph node. So
This is another lymph node,
we find it.
much bigger. So this is the hilum. So you are basically
Лен, иголочку.
You are basically in the duodenal bulb. Sometimes it's very difficult to biopsy lesion of the bile at the hilum. You have to be really keep your in this position. For example, the balloon is helpful because it can keep you the scope over the pylorus. But this doesn't look. It looks like a little bit easier than a hilar lesion, and it's big.
Yeah, this is very good.
Yes.
What would you say about the echo features when looking at malignancy?
So it's not rounded. So what you look is a dimension. So greater than 1 centimeter, apoechoic, rounded, and with the rounded margins. So this, it's not rounded. There's not the central hyperechoic tissue that usually is looks that the lymph node is benign. Is basically a fat tissue at the center of the lymph nodes. So this might be also inflammatory lymph nodes.
Okay, we just started the puncture.
So you're gonna go for cytology.
Yes. Okay, I have to come back to the stomach to see the
needle if it's coming out. Okay.
Я сейчас на буквально секунду выйду в желудок.
I'm just for a second, we'll go to the stomach to see the tip of the needle if it goes out of the device. And you can see in the endoscope. Это серия, первая серия, да? С новой серии.
Can have the 22 gauge is also there's a lateral opening, and we are yes it's out. So it's not gonna puncture the scope. That's good. the stone, or
I think
it's just a shadow?
just a shadow, maybe from air.
Евгений Геннадьевич, микрофон, не видим у вас микрофона.
Да, потому что я передал Альберто микрофон.
Again, you have no microphone. Yes, because I gave it to Alberto, and he's commenting on that. Я сейчас отдам вам мой микрофон.
Нам пришлось выйти немножечко назад в желудок для того, чтобы посмотреть.
Now we had to go to the stomach to see if the needle is out of the endoscopic channel. Now we have to go to the duodenal bulb, to what we saw. Now you see it again. I will put slit in place. And now you can see how the needle is out.
Okay. I don't use the stylet, for example, because it doesn't really change the rate of contaminant.
It's hot.
If you push.
Ну вот видно, что узел.
Now you can see that the node is rather dense. Давайте чуть больше продвинемся. Victor, can you see the ultrasound? Yes, we can see it. We do not feel how dense it is.
Chicken.
Вот сейчас мы находимся.
Now this is a needle inside of the node. And what is dense? What does it mean that it's so dense? Is the result of a chronic inflammation, or there are some suspicions? Well, without suspicions, we will not do such diagnostic search. But here, of course, here could be some inflamed node. It could be that dense. But as to the features, ultrasound features is just inflammation. Yes, as Alberto said, and with Alex they had such a nice discussion. It is really a truly inflammatory node.
Alberto, is it? What do you think about? Is it?
I think it's inflammatory.
Inflammatory. Yes, I think so. And Alex, what do you think?
Unless it's another disease, unless it's lymphoma.
Yeah. Okay, but this would be a very rare case.
Yes.
In the end. Yeah.
Евгений Геннадьевич, маленький комментарий.
Small comment that in case if the lymph nodes respond to the chronic process for a very long period of time, and if one of the components of inflammation is the immune component, then lymphadenopathy could be associated with considerable collagenization and even calcification. That's why we see some alteration, not because of some inflammatory cells, but because secondary changes are associated with enlarged stroma in the node. It could be hyperhygienic and could be dense, and with it could be calcinated, and it might even look like a tumor. Now we're done with biopsy.
I'll show you.
So you use stylet, suction.
И обратите внимание, что лимфоузел находится в непосредственной близости от аорты.
And you can see that lymph node is close to aorta. And regarding the technique of the puncture, there was a comment the use of stylet could increase the risk of contamination. Could you comment the types of technique and how it is related to the risk of contamination? Well, if it's possible we have such delay, could we move this question to the discussion? We would like to discuss it, but it looks manipulation is very long. What do you think about that? Let's discuss it. Yes, I'm positive about that. So we will wrap up with the manipulation, and we will call for the next patient. And now Sergey could finish up with his lecture. If you're okay with that, then okay. So then see you with the next patient.